Hello everyone, thank you for joining us today. I'm Jenny King, Chair of the Iuga Education Committee, and this promotion I'm delighted to have you all attending. Over the years, for those of you who are as old as I am, you might remember that we often had the conferences for ICS and Iuga in similar places in the world so that you could go to both. And for those of us who were urogynecologists, of course, we could always have an afternoon off when the ICS prostate section was on. But I shouldn't admit to that laziness. But really, over the years, we've had less and less events in common, and it is more difficult given the expense of organising conferences. So ICS and Iuga have very, very similar aims to do with promoting pelvic floor continence, prolapse, research education throughout the world. If we could have the next slide with our mission statement, this explains a little more of what we're doing. And as you can see, while our focus is on women, really these are very similar to the ICS goals. Now, in the next slide, you can see some of the activities of Iuga. And again, I think ICS provides some of these similar activities. But please look at it if you don't know much about Iuga and you've not been involved with us before. We've got great information on our website and lots of involvement. The next slide is just some details about our annual meeting in December. Unfortunately, it again has to be virtual, but it's really beautifully organised. So please come and join us, as well as getting the most out of this meeting today. So thank you, everyone.
Committee for ICS, International Continence Society, and we've enjoyed very productive partnerships with Iuga over the years, both in meetings and also in creating standards. ICS members receive online subscription to the journal, substantial discounts on meetings and events, exclusive access to ICS live events, research grants and fellowships, mentorship, and we really hope that you'll become involved and contribute to the society. Next slide. The ICS standards are free to all without any membership, and these standards, often in conjunction with Iuga and other organizations, do try to provide information through which to treat conditions such as pelvic pain, which is the subject of our talk today. Next slide. The ICS standards have also come together in a new document bringing together many of the major initiatives, and there's also the ICS glossary. Next slide. And you can find the latest terms on the glossary either on your phone or your computer, also for free without membership. Our next meeting will be in Vienna, 7th to 10th of September, and we anticipate that this will be an in-person event, and we're very much looking forward to it. So today's subject is what you need to know about pelvic nerve entrapment, and we thank Iuga and ICS for allowing us this opportunity and supporting it. What we hope to do today is to help you understand how to diagnose and treat nerve entrapment, looking at established versus cutting-edge approaches for nerve entrapment, giving you take-home pearls, and also strategies to refer for specialized care. We have Ernesto Delgado Cidranes, Nucelio Limos, and myself as moderator. Thank you so much.
Hello, everyone. For me, it's a big pleasure to share with all of you our presentation today about the one important topics in the pelvic floor is the nerve entrapment, the pelvic nerve entrapment. In this presentation, in my part, I want to talk with all of you the principal experience in that with the use of the different device or the different technique or the different protocol that we use every day in our habitual practice. It's a big honor to share this webinar with Dr. Elise and Dr. Nucelio. For me, it's a big pleasure stay here with all of you today. Now I need to share the the screen for the presentation. My first slide is here. Okay. Thank you so much for the institutional area of the Iuga and IACs. For me, it's a big pleasure. The title of the webinar is "What do you need to know about pelvic nerve entrapment?" Is fantastic. This is my advice for if you need to contact with me here in Madrid. Madrid is waiting for you in every time. For me, it's a pleasure to receive all of you here in Madrid. It's difficult for me to speak about in only 20 minutes about my passion, because it's my habitual practice every day in my surgery room, in my office. It's a good topic for me and for my team. For this reason, I want to share different devices like microendoscopy, laser, cryotherapy, advanced ultrasound that we use every day to identify the principal aspect in the pudendal entrapment, in the rectal nerve entrapment, or maybe different areas, different nerve that we found in the pelvic area. In this case, the first time I need to share with all of you that the more important for me is the anatomy. For this reason, we prepare for our student, resident, and any doctor, the course that the cadaver course or the cadaver course online workshop, online webinar for the people, for the student, understand which is the principal anatomy that you need to know for the approach of the pudendal of the nerve that appear in the pelvic floor. Obviously, my bet in this moment is the advanced ultrasound, because in real time, I obtain the best information. In this image, in this diapositive, in this slide, it's possible to understand that the principal, theme that you need to know in real time is the stage of the tissue. For example, if you have one nerve, it's possible to look if the nerve is in treatment, because in real time it's possible to see the structural area and the level of the canal alcor or the posterior area, or maybe you need to know, or it's possible for you to measure or to know the tone of the muscles around the nerve. And this is important because we have one important software in the advanced ultrasound, and the name is elastography. And the elastography, the qualitative and quantitative elastography with kilopascal and meter by second, is possible for you to know what happened in the tone of this muscle. And this is important because sometimes you produce one important release by surgery, or maybe by either resection around the nerve. After that, you don't know what happened after the procedures, or after the technique, or after the protocol, and you need to know which is the degree of the tension around the nerve after the procedures. And now it's possible with one important device like ultrasound, advanced ultrasound with transillumination, 3D, 4D, the 5D, to know what happened around the nerve. Looks one important example in this moment in the left. Is possible to understand that it's possible to look the nerve inside of the canal of the alcot, and to comprove what happened before and after that you use the hydrodissection. The black area, or the brown area, is when you put local anesthetic, the PRP, stem cell, or maybe sometimes I use hyaluronic acid to open this wave and to obtain more time. The nerves, the donut image is when I use the PRP, or sometimes stem cell or hyaluronic acid, I produce one important area that protects the nerve of the contact of the wall of the canal alcot. And this is important because when you use this technique, and that the name for me is the Prakau protocol, is our protocol, that I want one important paper For this, with the first case, and after that, I have more than 300 cases. It's necessary to understand that it is important to prevent the damage of the nerve. It's important the use of the high technology to evaluate what happened in the algal canal. For example, the left image is possible for you to look the pudendal nerve when passed through the canal alcot or alcol canal with trans-illumination. The trans-illumination is good because it's possible to evaluate in real time what happened with the microvascularization and the microinnervation, but fundamentally more important, the microvascularization to understand the flow Doppler. In the right, I explained for my student or for interdisciplinary team how it's possible to use in real time the advanced ultrasound to identify the alcol canal entrapment or the pudendal nerve entrapment or any nerve entrapment in the pelvic floor. Obviously, the high technologies should be the possibility to relieve the pain or to relieve or to increase the possibility that the nerves, the restoration of the nerve in the neurological stage of the neurological area. Imagine in real time that we use in the alcol channel and in the rectal space too, that is possible to obtain the best image and looks the change the diagnosis in your mind. You need to open your mind this moment because you have in static the static MRI or maybe the TAC in static information, and with the advanced ultrasound permit us the real information, the real-time information, and this is good for the procedures inside of our surgery room. This is more important for me. I want to explain for you, to share with all of you my important protocol for the pudendal relief, for the pudendal entrapment. That is the pain relief alcohol canal advanced ultrasound. The name is Krakow protocol. This is in the match, and the video is my partner, Dr. Estrada. He's a urogynecologist from Iuga too. We use the advanced ultrasound in real time to identify the pudendal area and decide what is the product, the final product that you need to put around the nerve to separate the nerve of the wall of canal alcol. In this case, I prefer obviously, I prefer always the stem cell than PRP, because the stem cell, the high, the more power of regenerative medicine, restore the function of the nerve than PRP from fat, or PRP, stromal vascular fraction for fat, sorry, and PRP from your blood. Is you need to know, you need to know that the best to put around the nerve is the bone marrow, because obtain more result, more increase the anti-inflammatory effect, and this is more good for the regeneration of the nerve. This is important. Look, the technique of the Krakow protocol. I use one special needle to the transperineal approach to obtain the best image of the nerve. Before and after the nerve, I put the PRP. It's important to the control of the tension, the control of the pressure of the PRP, stem cell, or local anesthetic, because depend of the number of kilopascal or meters by second, but for no increase the pathological pressure around the nerve. Remember that if you use more tension than normal, you have many vessels, for example, artery, venous leads, and another vesical space that is increase the tension and produce damage in the tissue. This is the final result when I use PRP or stem cell. Imagine of the hydrodissection in the alcol canal, the pudendal nerve, and I obtain one important image after these procedures, that the name is the CAG sign. Look, this is my first publication, my first paper that for the use of the Krakow protocol in 2017. I need to share with all of you my new CAG sign. The CAG sign is when you use the hydrodissection, the alcohol canal in the transversal cut it's possible for you to evaluate the artery, the venous, and the nerve, represent like image of the face of the cat. And for this reason, I put the name of the cat sign for this kind of protocol for the final result. Always appear this cat sign. But in the last year appeared another important device in my life and changed my mind and changed my possibility with the diagnosis and the resolution, because appeared one new device that the name is 7-star scope. Is a little microendoscopic, and in this moment with the use of the high resolution by ultrasound and the microendoscopic, it's possible to obtain in real time the visualization of the alcohol canal, and not only through advanced ultrasound. This is important because it's easy for me to identify the artery, the nerve, produce and to prevent the damage when you use a different technique. For example, I am very fan the use of the laser for to cut the fibrosis in the epidural space. I traduce for the PLB condition the use of this device, and I use in this moment a laser for to cut the fibrosis in different areas of the pelvic floor. Look, I put the laser, the fibers laser, through the microendoscopy, and it's easy to cut with a laser the fibrosis in the different area, in the rectal area, in the pudendal area, in the cluneal area. And this is more important because with one procedures, minimum invasive procedures, I obtain the best result for my patient. Look, another example of the fibrolaser pain. The fibrolaser is with neodymium yak, is administered through the very clinical optical fiber. I use one special cannula of radio frequency. The radio frequency that we use like anesthesiology experiment management every day, and with a little incision in the skin, percutaneous access, introduce the photonal laser for the control of the cut of the scar in this part of the tissue that we need to restore or we need to remove. This is the photonal laser, and look the image here in the right, that the access, what happened when you use the laser in the cicatrizal area or the scar area. Look, the scar disappears. You have the control of these areas. Of the more principle is that you suffer one important retraction for one important scar in any part of your pelvic floor. If you remove with the control in the real time through direct vision, you obtain safety and you obtain the best result, because it is possible to cut the tension that produce the retraction of the nerve. Imagine that you have one important area that is much harder than normal and produce retraction or traction of the nerve. If you put in the middle, when I use the elastographic, it's possible to prove that the area is more soft than before. For this reason, I use this protocol not only for remove the scar, if I use for the control of the tension of the tissue too. And this is more important. Look the device in real time, photona fiber laser and microendoscopic. You have look, it's very thin, and you obtain a good result of the definition in real time is very good, like laparoscopic, more or less. It's a big surprise for me in this moment, because the access of the canal alcott or any structural area that I need this device is important, because it's possible for me to cut the different scar fibers for to produce the release of the pudendal area, or the pudendal entrapment, or the nerve entrapment in any part. Look, another example. Imagine that if you have one area that is important for you to take the control of the vascular area because you have one important vessel or one important artery, or you need to look in all the moment the nerve because you want to evitate or you want to prevent the one important damage in the nerve, is possible to take the control. Remember that is not open surgery, is not laparoscopic, is only percutaneous access, is another tool. This is not the best than one surgery, obviously, and it's not the best that also is not better than laparoscopic. Is another tool for the control of the one kind of treatment in any part of your body. The name is 7-star scope, and this is the new microendoscopic that we use every day in my habitual practice, but it's safety for my patient as is more easy to the control of different symptoms and different problem of my patient in this moment. Look, when you increase the high technologies for to obtain the best result, in this moment I use the real-time visualization of the problem of my patient, and I combine in the real time the microendoscopic, and I combine with the use of the 4D ultrasound and 5D, that is the high resolution because it's the like a crystal, and it's possible for me to obtain the best result for the patient. And in the image of their arrive, it's possible for you to compare what happened before and after that you use or that you made the hydrodissection in the different area with the use of the elastography. Change the tissue. The tissue sometimes is more hard. You relieve the area, and after that, you relieve the nerve, and after that, you obtain one area more soft than when you start the procedure. And this is more important because remember, it's not easy to evaluate what happened after one open surgery or after laparoscopic. You need the final contrast was one another MRI or one TAC for the good definition of what happened or in this moment in what stage posterior to surgery have stayed the patient. No, and now in real time it's possible to evaluate with elastography and 3D or 4D ultrasound in your offices after 1 week or maybe 2 weeks or maybe 1 month. It's possible to you evaluate in real time if the pudendal relief is good, or maybe you have the pudendal relief of 50% or maybe 70%, that the results in the patient, that the evolution of the patient is possible to prevent, no, the complication, to prevent or to the predictive stage of the evolution of our patient. In another case with urologists, I use different techniques. We compare the experiences in real time in our surgery room. You know that I am anesthesiology, expert in pain management, but we work every day with urologists and urogynecologists that help me in the different procedures to prepare the different protocol for our patients. This is another kind of device that we use. This is the cryotherapy. It's important, the cryotherapy, because I have the control and separate with ice the different nerve to engulf and to produce hydrodissection too. This is the cryotherapy in real time, and we use elastographics too for the control of the different area. But the more important is to compare before and after with the use of the electrophysiological study, because if you put a stem cell, or if you use a cryotherapy, if you use PRP, or if you use any technique, you need to know to restore the functional nerve. And this is important for me because always in all the patients we use the electrophysiological study in the first stage, and after that, when I finish the protocol, I use then again the electrophysiological study. This is important. Sometimes I combine and I prepare before and after the tissue of this area, sometimes with chopped waste, sometimes with stone, And look, this one important device in this moment for pelvic floor that we use, that is by InMouth, that you put inside of the vagina and produce one, increase the tone, or maybe you need to prepare the conditional area, the structural area to restore the functional. This is one important device that we use every day, and you obtain one in final result in this area, in the three sector, anterior, medial, and posterior, and the result is very good for me and obviously for the patient. Obviously, the advanced ultrasound is the best for me in this moment because it's not invasive procedures. I obtain the final resolution of what happened after any procedure that we use for relief the pudendal entrapment. The nerve of the rectal area is the same because we have the control in real time, throws vision, direct vision, and this is good, and I prepare or prevents any problems with the use of the PRP or stem cell. Then remember, structural area, functional area, and nerve area are different conditions that you need to know to prevent or for you produce a good relief of this symptom of problem of the patient. The restore the function is the more important. Another example more of the cryotherapy in the patient. Another device that we use, but we don't have more time in this moment, and it's possible for you make any question on any doubt that you need to know. I am here, and for me it's a big pleasure to share with all of you in this 20 minutes my principal experience with the use of the different devices and different techniques in pelvic floor condition, specific call and entrapment of the nerve areas. Thank you so much.
Hi, my name is Nocelio Lemos, and I'm here today to talk about intrapelvic nerve entrapments. I thank you very much for the opportunity, and I hope we have a very productive session. In order to improve the quality of the transmission, I'm going to turn off the camera. And today, before we start, I have to disclose my conflicts of interest. None of them are relevant to this lecture. So the objective of this talk today is to review the anatomy of the nerve bundles crossing the pelvis, discuss the main steps where nerve damage can occur during gynecologic procedures and strategies to avoid it, relate the symptoms and signs resulting from intrapelvic nerve entrapments, and our strategy to tackle them. So when we talk about intrapelvic nerves, we're basically talking about the whole anterior division of the lumbosacral plexus. And it's very important to understand the anatomy of those nerves, as well as the dermatomes and myotomes of those. So I've created these schematics that we're going to use throughout this presentation that basically has on the left-hand side the drawing, the schematic drawing from Natter or some other anatomy book. And then in the middle column here, we're going to have the dermatome of that nerve and then the myotome of that same nerve. So when we talk about intrapelvic nerves, we're talking about three main groups. The main reference we have is the psoas muscle, and we have the genitofemoral nerve, which is the only nerve that emerges from the anterior border of the genitofemoral of the psoas muscle, and then the nerves that originate from the lateral border and from the medial border. So let's start then with the genitofemoral, which innervates this area here in yellow, and the only muscle it innervates is the cremasteric muscle. Laterally to the psoas, we're going to have the lateral femorocutaneous nerve, that innervate the skin on the lateral aspect of the thigh, and it's a sensory-only nerve. The etohypogastric nerve, that innervates the light blue area here, and the ilioinguinal nerve that is sensory only and will innervate this purple area here. So when we talk about nerves, it sounds like we're talking about very deep structures, but let's look at this. We're just going into the abdomen with the camera and looking at the left pelvic side wall. This is the external iliac vessel. This is the left ovary, the left colon, and the IP ligament. And look at this. Just from transparency, you can see the nerves. We have the genitofemoral, we have the lateral femoral cutaneous, and the trunk that will form the ilioinguinal and iliohypogastric nerves. By simply opening the peritoneum, we get access to all those nerves. And lack of this understanding creates problems already on abdominal incision. Most of us are trained to place our ports using the anterior superior iliac spine on laparoscopy. But the problem is that reference is the main reference for injuring the nerves. So what I propose is that we use the laparoscopic vision when placing our port. So we have the lateral border of the rectus abdominis. Of course, we have to pay close attention to the inferior epigastric vessels, not to injure them. And then just laterally, as close as possible to the rectus abdominis, we're going to place our port within this white triangle here. So remember, the nerves run in fat, and the less fat, the less likely it is for that nerve to, the tissue to carry nerves. So look at this. That's where we're placing. You see the white triangle here, and as close as possible to the rectus abdominis. Deeper on the lateral aspect of the psoas, we will find the femoral nerve. It's a very important nerve because it's almost the sole innervation of the quadricep muscle. So the whole extension of the knee relies on this nerve, as well as the innervation of the anterior thigh and leg. Following the QR codes here, you can see the videos into full context. But basically, this is a dissection of the femoral nerve, just laterally to the psoas. The genitofemoral, the lateral femoral cutaneous, ilioinguinal, and the femoral nerve can be damaged doing psoas hedge procedures or with misplacement of retractors in laparotomy. Then finally, we move to the medial bundles. So the bundles that originate from the medial aspect of the psoas muscle, which are the obturator nerve, the lumbosacral trunk, the superior gluteal nerve, sciatic, the inferior gluteal nerve. Some patients will have a variant of the posterior femoral cutaneous originating already into the pelvis. The pudendal nerve and the nerve to the levator ani. So the obturator nerve innervates the skin on the medial thigh, and as well as all the adductor muscles. The dissection for the obturator nerve starts with the developing of the obturator space. Here you have the genitofemoral on the anterior aspect of the psoas, and then dissecting down on the right pelvic side wall, we'll see just past the external iliac vessels, the obturator nerve. We'll then carry down with our dissection to find the lumbosacral trunk, as well as the superior gluteal nerve. So here is the obturator, we're carrying down, and then over the SI joint, we'll see the lumbosacral trunk. And after the merger with S1, we'll see the superior gluteal nerve running to the right side. The next nerve in our dissection is the sciatic nerve. So you can see here we're carrying it down towards the ischial spine, and then here's the sciatic, superior gluteal state here. And this is the pubocervical fascia. The ischial spine is just behind this bipolar here, and this is the sacrospinous ligament. We then carried on with our dissection towards the pudendal nerve. So we're opening up the sacrospinous ligament. And then after that, we'll open the Alcock's canal. And here you can see the site of entrapment. Finally, we can also dissect the sacral nerve roots on the presacral space. So the more lateral aspect of the plexus was dissected through the iliolumbar and obturator spaces. And now, to dissect the sacral nerve roots, we're going to start our dissection at the level of the promontory. So we're opening up here the peritoneum. Opening up now the presacral fascia and then developing the presacral space. The lateral limit of the presacral space is the hypogastric fascia. We open the hypogastric fascia to find the piriformis muscle, and lying on top of the piriformis muscle are the sacral nerve roots. Using intraoperative nerve simulation, we can see that this is S3, this is S2, S3 again, you can see the levator plate here being stimulated, as well as the rectal peristalsis and the bladder contraction. And this is the neuroanatomy of the pararectal fossa. Well, here we have the hypogastric fascia open here. This is S1, S2, S3, and S4 is just behind here. These are the pelvic splanchnic nerves originating from the sacral nerve roots. And this is the inferior hypogastric plexus, just medial to the internal iliac vein. So we also have the autonomic nerves into the pelvis. And understanding this anatomy is important to understand the visceral symptoms associated to intrapelvic nerve entrapment. So intrapelvic entrapment can cause refractory detrusor overactivity, refractory urinary urgency, fecal urgency, and rectal pain. Again, when we talk about those nerves, it seems that we're talking about structures that are far from our daily practice. But if you follow this QR code and get the whole picture of this video, you will see that this is a detrapment we performed associated with the fibrotic process undergoing this area of the peritoneum here. And this space does not exist. I had created it for the nerve detrapment. But look how close we are to the sciatic nerve. This was the area that was attached to the sciatic, and we're talking about a 1 to 2 centimeter distance from the peritoneal surface. And the lack of awareness of this causes situations like this one, where we have a McCall suture on the S2 nerve root. It looks like something extreme, but it actually happens in up to 7% of women undergoing a typical vaginal hysterectomy with an uterosacral ligament suspension. And learning how to recognize those situations is very important to avoid nerve degeneration, because the longer the nerve is entrapped, the more advances the myelin sheath disruption is going to be, and the least likely to revert the process will be. So we need to learn how to diagnose those. And the most important part of this diagnosis is understanding the concept of peripheral entrapment neuropathy, which is a clinical condition characterized by the mechanical entrapment on a single nerve or nerve root. And its symptoms include pain, tingling, numbness, and muscle weakness on the affected nerves, dermatome and myotome. And the most important part of this definition is the dermatome and myotome part here. So we need to be familiar with all the dermatomes and myotomes of the nerves I just described, and understand that although Alcock's canal syndrome and pudendal neuralgia are cited as synonyms in the literature, only 8% of our cases of intrapelvic nerve entrapments happen at the level of the Alcock's canal. All entrapments happen, most of the entrapments happen in the most proximal areas of the lumbosacral plexus. And their symptoms will, of course, not be chronic pelvic pain, but pain on the dermatomes, on the viscerae, on the muscles innervated by those nerves. So nerve entrapments can be caused by endometriosis. So as you can see here, this is S1, this is S2, and you see how dilated the nerve root is. And that's because there was an endometrioma inside of the nerve root. It can be caused by sutures or grafts or fibrosis, as I've already shown you. It can be caused by entrapments, by vascular entrapments, neurovascular conflict, varicose veins of the internal iliac system entrapping those nerve roots against the pelvic sidewalls. Removal of the veins is essential here, because if you embolize them, the recurrence rate is over 70% in 3 months, and detrapment is more difficult with the scarring and fibrosis that is caused by embolization. Muscular entrapment is also another cause of intrapelvic nerve entrapments. It is the piriformis syndrome is very well known and has been described in 1938 by Beaton Anson, who described these 5 anatomical variants that could cause entrapment of the sciatic nerve in the deep gluteal space. Many other variants have been described, and what we've just figured out is a group of people who have an entrapment due to a bundle, an abnormal bundle of the piriformis originating medially to the sacral foramen. So look at this. We have the abnormal bundle here. This is S2, this is S3, and that can be this abnormal slip here can entrap these nerves against the normal or the regular piriformis fibers. The problem is this anatomical variant is present in about 30% of the population. So clinical assessment is, again, key. Just finding the variant is not an explanation. This video is also very interesting to describe the the mobility of these structures. And this concept is key to understanding how the tethering of those nerves can cause pain. And secondly, to demonstrate how we can use this mobility to avoid adhesions in the postoperative period. Finally, the fifth cause of intrapelvic nerve entrapments are nerve sheath tumors or metastatic tumors to the lymph nodes. So as you can see here, this is a neurofibroma into the sciatic nerve. We're opening up the nerve sheath. And then removing the tumor with a minimally invasive approach. The surgical outcomes of these techniques are these: a success rate of about 78%, which looks good. But if you split that and go look into the number, what we see is that we have a 43% cure rate and 35% improvement rate. Although it was a very strict improvement rate that demanded for more than a 50% reduction in the VAS score, where most of the chronic pain literature will consider success as reduction in 30%. It's still pretty frustrating. But when we split the numbers or cases between opioid naive and patients with chronic opioid use, we'll see that the success rate in opioid naive patients is 91% versus 35% only on chronic opioid use patients. So, but even if we look only at the opioid naive, half of our patients still have some residual pain after surgery. So what we've been developing now is targeted therapy delivery. So this is a nerve detrapment of S2 that was the narrowing of the nerve root. And what we're doing here is putting a catheter right at the site of entrapment and connecting it to an infusion pump. That is placed subcutaneously and can be refilled. And we use it to infuse local anesthetics. Well, the surgical outcomes with the pump are much better still than the patients without the pump. Look, we of course got patients with a bad prognosis, patients with longer periods of pain or failed hip procedures. And this is their post-op pain at 1 year, but this is the pain control that was achieved with the pump activation. These numbers also show us how important it is to have an early diagnosis, because at the moment, these patients go into chronic pain programs that start prescribing them opioids. They're basically doomed to failure. So we're trying to invest on the use of MR tractography for the diagnosis of these, and the results are actually pretty exciting. So basically what we look for are areas of reduced anisotropy, or where there's a smaller multitude of colors here on the tract, which means that the direction of the hydrogen ions is more organized, the flow is more organized, showing that the ions are looking for the path of least resistance. And in extreme cases, what we see is the signal gap, like this one. And the results are very exciting and very promising. So these are initial case series we have basically compared the tractography findings with the intraoperative findings, as well as the neurography findings with the intraoperative findings. So if we go to the current most used method for assessing the intrapelvic nerve bundles, which is MR neurography, we see that it correlates with intraoperative findings in only 2 out of 13 cases. And tractography has correlated with 11 out of 13 cases. And if you remove the patients that had orthopedic hardware, this was a perfect correlation. So in conclusion, a thorough understanding of the deeper structures of the pelvic side walls is essential for increased radicality and reduced morbidity in the treatment of endometriosis and other pelvic neoplasms, as well as for safely performing female pelvic reconstructive procedures. The signs of intrapelvic nerve entrapments are related to the dermatomes of those nerves, which include perineal pain or pain in the sciatic dermatome with motoric deficit in the lower limbs, or lower urinary tract symptoms associated with gluteal pain or perineal pain, tenesmus, either rectal or vesical tenesmus associated with perineal and gluteal pain, rectal or vaginal fun and body sensation associated with the pain on those dermatomes. Topographic and etiological diagnoses are essential for a specific and effective treatment of pelvic pain, and most refractory cases are due to incomplete diagnosis. Careful anamnesis and physical exam focused on a topographical diagnosis are the most important part on evaluation, and complementary exams have little specificity and must be oriented to confirm a specific hypothesis. Screening exams will mislead more often than not. So I hope you've found this presentation helpful. There are more resources here following these QR codes, and this is my email address for any questions that you might have after the discussion. Thank you very much.
Wonderful. Thank you both so much for the really informative presentations. We'll be able to go back and look at them because they will be available on the Iuga website. And there are a lot of good questions. I'd like to start with one. So Dr. Cidranes, as a neuroanesthesiologist working at University of Madrid, and Dr. Limos as a gynecologic surgeon and neuropelvologist working at University of Toronto, what would you recommend to the average viewer who might not have all of the specialized skills or technology that you have about the initial management of pelvic nerve entrapment that's suspected, and when to refer for more invasive treatment?
Yeah, thank you so much for the introduction, Dr. Elise. For me, it's a pleasure to share with all of you, and specifically with you and Nucelio in this webinar. For me, the principle is the first stage is the diagnosis of this pathology. We have one important protocol when the patient arrives, or when different specialists send me his case or her case. The first stage, obviously, is the examination and the control of the neurological study in the moment that they suffer the patient the symptom. And for example, for the first, my first plan is to send the neurologist and neurophysiologist study to obtain the electrophysiological study of the nerve, because if you have in this moment the patient suffer one important pain, you need to comprove what happened in the structural area and what happened in the nerve, and for the prevent, or for the form, the definition of what do you need to know, or what do you need to do to restore the functional nerve. And the first question, my first key point is to find what happened in the nerve, and the electricity of the nerve is possible to evaluate only by electrophysiological study. And for me, this is one important point. And second, I use the MRI with contrast for by radiologists to understand what happened in the structural area. And after that, I use advanced ultrasound always, because it's possible for me to evaluate in dynamic stage what happened with the muscle, with the ligament, with the tendon, with the functional area in this moment. I have one important question, that what is my probe favorite with advanced ultrasound? And I use always the volumetric probe of in my advanced ultrasound, because permit me in three-dimensional stage to understand what happened. Obviously, if you have one important machine, you have transillumination and you have elastography, and it's possible to evaluate what happened with the muscle, what happened with the elastography, what happened with the elasticity and degree of the deformation of the muscle. And this is important for me. For this, in my opinion, we have three elements for the diagnosis: the electrical study, the structural study, and the dynamic study. And obviously, the physical examination, for example, my patient received one important diagnosis by physical therapy specialist, and we are a big team, an interdisciplinary team, and this is more important after the definition of which is the conduct, which is the treatment that the patient needs to receive.
Thank you. Dr. Lemos, could you please speak? This is the International Continence Society and International Urogynecologic Association. So it's possible that not all of those watching have access to ultrasound and MRI for diagnosis and initial treatment. Can you speak to those who really don't have that equipment?
So the main thing is the dermatomeric distribution of pain. So this is the main symptom that needs to pop up, and we have to be aware of, and consider the referral to the patient, because if they have a nerve entrapment, they need to be referred to a center that is equipped to treat nerve entrapments, to diagnose and treat. But the main thing is the dermatomeric distribution. And the main challenge is to figure out if the entrapment is within the pelvis or outside of the pelvis. They can be in the deep gluteal space. They can be in the Alcock's canal within the pelvis. And it's funny because my experience is exactly the opposite of Ernesto's. In our experience, we have never managed to use electrophysiology for diagnosis. We find that the overlap between normal and abnormal ranges and legs is too large. So basically, ultrasound. I have tried to work with the best sonographers I've ever met, and they themselves think that the ultrasound was not useful for any kind of diagnosis of nerve entrapments, and they themselves recommended the use of MRI. In particular, Manuel Orlando Gonçalves, who is probably the most published and most successful advocate for pelvic ultrasounds in diagnosis of endometriosis, and he created most of the standard techniques of today. So we're still trying to look for an objective diagnostic method. We do not have a good one yet. We're hopeful that tractography will play that role, but we're still analyzing the sensitivity and specificity and the positive and negative predictive values of MR tractography. But currently, what we do is we will do a neurological exam. We will look at the pain patterns, and the pain patterns are the most important part. Then, of course, a neurological exam will do imaging to analyze the anatomy. So basically, a high definition MRI, a 3 Tesla MRI of the pelvis, and then a diagnostic block and before the diagnostic block, we also use urodynamics in our analysis. But after we bring all of those tests together is when we indicate surgery. The accuracy of any of those in isolation is not good.
So we, in the interest of time, I'm going to move on to the next question because we're nearing the end of our time slot. We'll go over a little bit, but we won't keep people for too long. On a related question, Luis Lopez Fondo is asking, do you think with the advantage of imaging, tractography, and or ultrasound nowadays, is necessary to perform infiltration previous to offering surgery? And I think what he's asking is, can you do a diagnostic injection without imaging? Is that, do you read that the same way?
So my impression is the nerve block is essential. And the way we do it is very low volume, strictly diagnostic block before we try any therapeutic intervention. So yes, my answer is the way we approach it. Yes, a block is mandatory. What do you think, Ernesto?
I think that the same that you, because the problem is that I changed in my last years, in my experience in the last year, I changed my opinion about that because obviously I made the block always in all my patients. But the first stage in my life in the treatment of pelvic floor, I used the block of posterior way always. But now in this moment, I change for the transperineal area. And the result is more good for the definition of the diagnosis and therapeutic block. And sometimes, for example, with the patient refer the symptom in the posterior area, I use always the block for posterior area in the ligament in the area of the posterior sacral area. But when the patient refer a symptom of the urethral area, or maybe cystitis, or maybe perianal area or perianal damages, I contrast that electrophysiological study, any problem with my blood is always transperineal in real time through the direct vision with advanced ultrasound.
Another question from Rebecca Doss, and let's try to make our answers shorter so we can get through everybody's questions. How much pain relief on nerve block is required to consider it a successful diagnostic process?
For us, it's 100% pain relief for at least for the duration of the block. The pain has to go completely away. At least the dermatomeric pain has to go completely away after the block for at least a couple of hours.
Ernesto?
For me, with 2 hours of pain relief is sufficient to evaluate if the block is good, because the patient arrive in our clinic, in our office with a terrible pain, and when you put the block and the patient is relief of this area, which is the positive, for me is the positive.
100%?
More or less 66%.
Okay. And Jane Mejlink is asking, Nucelio, could it also cause bladder pain? I think she's probably referring to pudendal nerves.
So yeah, the pudendal nerve will cause mostly urethral pain, but entrapments of S2 and S3 nerve roots, so higher entrapments, they often cause bladder pain syndrome.
Okay. Let me see. Glenda Barreo is asking for Dr. Cidranes to please go over the CAT sign again. Could you just briefly break it down for us?
Okay, the CAT sign is when I use three-dimensional exploration with advanced ultrasound. Is you could in longitudinal, you don't have, it's impossible to obtain the CAT sign. When you could in three-dimensional exploration, the alcohol canal, and after that you produce, or after that you obtain the hydrodissation on the canal of alcohol, you obtain 3 images. 2 in the upper of the image, that is the eyes of the cat, that is the pudendal nerve, the two rods of the pudendal nerve. Under of the 2 appear another, this is the principal rod of the pudendal nerve, and you have 3 images, and this is in the transversal cut. For this reason, when you make the hydrodissection of alcohol cannon and you cut in transversal area and transversal cut, you obtain this image in 100% of the expiration.
Okay, and these videos will be archived so everyone can watch the actual presentations again. This is from Angamutu Aronkalev. For Dr. Sidranes, what is the best mode of pudendal block? As PRP, is it available easily everywhere?
Wow, this is
Oh.
this is an important question because
Oh,
always
it's as PRP is available easily everywhere, is this good enough?
yeah. For example, PRP is good, but the problem with PRP is only one. You need to restore the functional area of the nerve. You need more or less for restore the functional nerve. You need more or less 6 weeks until 10 weeks in normal condition after damage. But when you put PRP, you obtain the PRP around the nerve is only 3 weeks or maybe 4 weeks. The rest of the anti-inflammatory or the different effects disappear in only 4 or 5 weeks, and maybe in some time it's not sufficient for the control. It's sufficient for the mechanical the PRP prevent in the mechanical damage because separate the nerve of the wall. But for me, the best is the stem cell, of which by when I obtain this stem cell from bone marrow. But the problem is that the bone marrow is more expensive.
And Dr. Sidranes, this is from Caitlin Jotard. What are the results?
Before you go ahead, Elise, there was one point here that I think it was not answered. They asked what is the best mode, and I believe it should always be image guided. So for diagnostic purposes, it has to be image guided, and then the image can be ultrasound or CT or fluoroscopy, depending on the target nerve that you need. So, just as a take-home message, some things that are that we know pretty well is one, the main clinical sign is the dermatomeric distribution. Two, diagnostic ultrasound has to be image guided with very low volume, no corticosteroids. So because we wanna see the response from the anesthetic block itself, very low volume, so 2 to 3 milliliters only on the site of entrapment, and we expect 100% pain resolution for a couple of hours if you use bupivacaine.
And the point being with the ultrasound or fluoroscopic guidance that you want to be sure you've actually targeted the nerve.
The nerve at the level that you think the entrapment is.
Okay.
So because you want to use very low volume. If you do a spinal block, everybody's pain goes away, right?
So you can't use too much.
Yeah, exactly.
Thank you. Kathleen Jatard, for Dr. Sidranes, what are the results of your therapy on short and long-term pain?
Yeah, normal when I use, for example, when I use PRP around the nerve, the best result is only until 6 months or maybe 7 months. If you use, I prefer the combination of the PRP with hyaluronic acid because it's more long, the effect is more long than the only PRP, and more or less is 1 year or maybe 1.5 years. And when I use ice, when I use cryotherapy, the result is until 2 years, and when I use a stem cell, is until 3 years, more or less.
But what is the success rate?
More or less, for example, I use the best for me is the use of the stem cell from bone marrow because I obtain the best result, but more than, for me it's good, Nucelio, more than 66 or 70%, because sometimes the patient that we use the regenerative medicine, I use regenerative medicine like another toll, not the first stage for this kind of patient.
In an objective way, Ernesto, you're saying that 60% of the patients that you inject with bone marrow get pain-free. Is that what you're saying?
Yeah.
Pain-free or improved?
Through.
Improved.
Improved. So,
Improved.
and what is your criteria for improvement? Is it the general 30% criteria, or 50%, or 70%? What is your
70%?
30%?
Yeah.
Okay.
Thank you.
Yeah, we use more strict criteria for surgery.
Mm.
Use 50%
50.
pain reduction at 1 year follow-up.
Measured how, Nucelio?
Numeric rating scale and visual analog scale. So then we do the average. And we only consider 1 year follow-up because there's a lot of placebo effect with the intervention and all of that. So if you look at the failed patients, their pain is all over the place. Actually, the whole group is all over the place because when we do the detrapment, there is a 40% chance of post-decompression pain. When you have a nerve entrapment, there's myelin sheath degeneration, and then the axon starts expressing sodium channels throughout the whole extension of the entrapped area, and that creates a mechanosensitivity. That's what led us to start implanting the local anesthetic pumps. So my opinion is for nerve entrapments, less than 1 year follow-up is not very useful clinical information. All outcomes have to be measured at 1 year follow-up.
What do you think your rates are at 1 year, Ernesto?
Oh, I think the same. I have one in relation with this. I have one important question for Nucelio. What do you need, or what do you use after the surgery, after the laparoscopic surgery, when you produce a relief of the pudendal entrapment? How many times do you need to evaluate the work result of the pudendal relief?
1 year.
Yeah.
That's the thing. With the nerve blocks, what we because we work with the interventional anesthetist here, and then of course with the nerve blocks, what we consider is not 1 year after the initial block. What we consider is how long can the block keep the patient's pain under control, and how many repeated blocks the patient needs, and then how effective is the nerve block at 1 year? Like, are those nerve blocks at 1 year for controlling pain? Our experience with nerve entrapments is for endometriosis, it's not effective. For vascular entrapment, we got about 30% pain control with nerve blocks. And then for muscular entrapment, we always tried the nerve blocks associated with Botox of the abnormal piriformis bundle, and we got about 50% success rate. And then in patients who have failed physio, right? Only. So
physio first, obviously.
We
try everything together. We try to. Our philosophy is that you go with everything that is minimally invasive all at once. So we try medication, physio, psychotherapy, because stress management is super important, and the nerve blocks. So because it's very minimally invasive, right? It's just local anesthetic with some corticosteroids and sometimes Botox.
For us in this moment, it's a big problem, the scar after the surgery. By laparoscopic or open surgery, this is a big problem in the world. For example, not only in Spain, not only in Europe, in the rest of the world, around the world. For this reason is the development of this protocol with the use of the laser, because we have a big problem. Because, for example, the surgeons resolve or remove the entrapment of the nerve, but the problem is that after 3 months or maybe 6 months appear new scar in the patient, and we have the pudendal entrapment, or sometimes the critical case, because you have the pudendal entrapment again, repeat the clinical case, but you have another problem. You have the retraction of the nerve.
So that's interesting. And then that depends on post-operative protocol. If you look at our data, we have 0 recurrence in pain. We have 20% failure. They fail right away. They don't recur. But we have, as I said, our patients have already failed all those initial non-surgical therapies. And then we have specific protocols for plexus mobilization that we teach the patients. They start mobilizing the plexus exactly 10 days after surgery, 10 to 14 days after surgery, when the scarring is still breakable. We teach them nerve flossing exercises, pretty much as it's done in extra-articular hip surgery. So we got those exercises from Hall Martin at Baylor. It's the genius of deep gluteal nerve entrapments, and we do that, and we actually do have 0, and we have very good data control. We follow our patients actively, and if you look at our data sets, we always have less than 10% missing data in our active follow-up.
Well, there's a real art to this field, as we can see by the differing approaches and the data. I think we can all agree, the better we study these patients, the more we're going to be able to provide in terms of education and treatment in the future. Sorry. We have one more question from Rebecca Doss, and it's 8:16. So do you see pudendal nerve entrapments following anal sphincterotomies?
I don't think it's possible for an anal sphincterotomy to cause a pudendal nerve entrapment.
My initial reaction to that question was I could completely picture secondary entrapment, secondary to pelvic floor, high tone after a sphincterotomy.
For me, this is a big problem in this moment. For this reason, I incorporate in my team and in my different hospital the future in real time the use of the physical therapy, because the tone for me is very, very important. Sometimes when you produce or you make any surgery or any procedures, invasive or non invasive, the tone and the muscle of the pelvic floor change, because it's the biomechanical defenses of this area, and increase the pressure and increase and change the elasticity and change the structural area. And for me, the tone is the principal key point in this moment, because I need to evaluate if the patient needs Botox or the patient needs botulinum toxin. Sometimes I have one important pudendal entrapment with only 100 units of botulinum toxin. I resolve the problem of the patient, because the patient relaxes this tone, and the physical therapy completes the best result of this kind of patient. For this reason, for me, the tone is a key point by elastographic, and I put not only the tone by radiofrequency. I increase the tone in the hypotonic stage with the use of the magnetic fields for the treat of this kind of disease in this patient.
Thank you. Any closing points you have for our viewers about approach to this patient population?
So I think although it sounds like the approaches are very different, they actually are not. What Ernesto and I are saying are pretty much the same thing. We try not minimally invasive approaches as first-line therapy. The patients that he described with failed surgery, scarring, and all of that are patients that probably one had poor diagnosis or non-integrated management. Complication rate is actually pretty low for surgery or for those interventions at specialized centers, but they only make sense if they're part of a grander integrated care. I do not believe in one physician operating and doing surgery and that's it, or one interventionist. We see all the time, like it's a scandal after scandal here in Canada of pain clinics that only do like anesthetic injections for billing purposes. So it all has to be integrated, and so I think that the most important take-home message is good diagnosis, very specific diagnosis. And every time you say nerve pain, you have to say it's a proximal S2 nerve root entrapment, not nerve pain. And then specific interventions aimed at the problem with physiotherapy, with multi-professional care, physiotherapy, and mental health support, and interventions, and when those fail, surgery. That is, I think that should be the main message.
Okay.
No one can deliver care alone.
And Ernesto?
Yes.
Any closing comments?
Totally agree with my dear colleague Nucelio. I think that the first is the diagnosis. To discuss the diagnosis with the interdisciplinary team. For example, it's impossible. I am expert in pain management. I am anesthesiology, but I need to evaluate these different patients. I need the urologist, the urogynecology, the gynecology, the physical therapist. It's totally my bet in this moment. Is different points of view that you need to restore the functional patient, and for me, is totally agree with the words of the Nucelio.
Okay, wonderful. Well, we'd like to thank you both so much for your expertise today and your wonderful colleagues, and keep doing what you're doing. The webinar will be made available on demand for Iuga and ICS members via the website. So thank you and goodbye.
All right, thank you.
Thank you, Elise, for all your leadership and pelvic pain, and thanks for the ICS and Iuga for the opportunities to spread what we've been doing.
The same for me. Thank you for the opportunity. For me, it's a big pleasure to share with all of you. Bye-bye. Have a nice day.
Okay, bye.